How do we how do we do that? Well, we don't, but some folks are occasionally kind enough to email us in advance and tell us they have a wonderful case. And in this instance, it's actually our dear friend Api, who has been on vacation this week and has spent a lot of his vacation on Virtual Morning Report, including discussing a couple times this week. So Api, please unmute yourself, reintroduce yourself to the VMR crowd. And after that, Prof. Raz will say hi, and then we'll jump right into the case.
Sure. So my name is Appy. I'm a first year intern in internal medicine at Mount Auburn Hospital. Yeah, so as you mentioned, this week is my vacation, and I spent a lot of my vacation on the virtual morning report, and I enjoyed joining the virtual morning report.
Welcome, Api. Thank you so much for joining us. We're very, very excited. And since Robbie showed his friend, let me show you my friend if he gets up. Hey, get up, Lenny. Lenny. Okay, never mind. He's sitting on my feet, keeping me warm. But maybe when he gets up, I'll show you my friend. So, who is scribing today?
I'm doing teaching points.
Okay, wonderful. Do we have anyone scribing?
Let me look at the board.
What's up?
This is Mr. Lenny. Lenny, say hi.
Hi, Lenny. What a cute harness. A green harness is really cute.
Say hi. Show your beautiful face.
Lenny.
All right. So,
Kiara. Kiara is scribing.
Okay, wonderful. Kiara, do you want to take over the whiteboard so we can get the case going?
Okay, so should I get started?
Let's rock and roll, my dear friend. Let's get your Friday vacation day off to a bang.
Sure. So I have an interesting case of a 67-year-old female who presented with chronic cough for 3 months.
Robbie, go please. Let's hear your beautiful voice.
Chronic cough for 3 months. You know, I will be honest, most chronic cough is not interesting, but we already are biased because we are told by our dear friend that this is a chronic cough. Let me tell you to be careful. Be very careful. What you choose to form a schema around is crucial. If you find and you realize that you're solving the wrong problem and going down the wrong schema, you're going to be led significantly astray. Do not think about chronic cough yet. Why? If you later learn that this chronic cough is accompanied by shortness of breath, all the common causes of chronic cough are out the window. If you later learn that this patient has shortness of breath, ACE-induced chronic cough, smoking-induced chronic cough, gastroesophageal reflux, cough variant asthma, and upper airway cough syndrome are all not at play. So when you hear chronic cough, pause. Study the presence or absence of any accompanying symptoms. And if you find an accompanying symptom, the only thing you know is that the cough suggests a pulmonary component of that disease. So when you hear the words chronic cough, pause, study the landscape. Is there anything else going on? If the answer is yes, follow that lead and use the chronic cough as a small piece of the puzzle telling you there's a component in the lungs. If the chronic cough takes up the entire space of the diagnostic landscape, it's a different conversation. And that's where the most common causes of chronic cough reemerge, which we just mentioned. So that's what I'll say about this. Careful. Don't jump into the wrong schema. I'm very, very suspicious that we're going to have an accompanying feature. Why? We're on VMR, unless this is upper airway cough syndrome. But I'll hand the mic to Prof. Rez if he has anything to add, and then to get more data.
Zero.
Okay. So let's move on. So all the I'm sorry. Cough started around like 3 months ago. She described the cough as like a dry cough without any shortness of breath, no chest pain, no runny nose, no fever, no weight loss. However, for the past month, her cough has been progressively worsening to the point where she could not lie on the bed because it sounds that her cough is aggravated by the supine position. So she has to sit on the chair to sleep. Other symptoms, she reported fatigue, decreased appetite, and unintentional weight loss for around 10 pounds over the past several months. She also got tested with COVID-19 for 2 times, which were negative. Other than that, she denies any leg swelling, no fever, no hemoptysis, no hoarseness. Review of system is positive for polydipsia and polyuria. Other than that, she denies any sick contact, no TB contact, no history of TB, no COVID-19 exposure, and no recent travel. Past medical history is significant for hypertension and OA knee, where she takes lisinopril 10 milligram and Tylenol as needed. Family history is non-contributory. Social history, so she is non-smoker, not the secondhand smoker either. No alcohol drinking, no illicit drug use. She is independent at baseline, lives with her son. Allergies, no known drug allergies. And I'm not sure whether like the second aliquot include the vital sign, physical examination or.
I think this is tremendous. The case just got very exciting. Just like the mathematician warned us, he said, don't let the chronic cough serve as your center of gravity. But of course, the final diagnosis must explain this patient's chief concern, which has been bothersome for the past 3 months. And what I'll do is I'll tackle some of the foreground and then hand the mic to Robbie to sort of add to my discussion and to tackle the background information. We were told that this cough changes with position. So it seems like it's exacerbated by lying supine to the point that the patient has to sleep upright. Of course, we don't commonly think of cough as postural, but we have something to use analogic reasoning through. And what is that? That's orthopnea. Or if you actually read Arsalan Derakhshan's paper, which was featured in NEJM Journal Watch, orthopnemia or pseudoanemia. When patients lie supine, fluid leaves the interstitial space and goes intravascularly. This means more fluid returning to the right side of the heart, which means more fluid in the left side of the heart, which means more fluid to the kidneys, which means more urination at night, or pulmonary edema in those with heart failure. As far as hemoglobin goes, what Arsalan showed was that patients going from an upright posture, sitting in the chair, getting their hemoglobin checked versus lying supine, when they lied supine, their hemoglobin dropped on average 0.5 gram to 1 gram per deciliter, just from the change in volume, which is quite striking. So with regard to the cough, the fact that it worsens lying supine brings to mind a couple of considerations. One is GERD, gastroesophageal reflux disease. These patients, if they eat before they go to bed, when they sleep at night and they lie supine, you're taking away the effect of gravity. So you're going to have increase in reflux. The same is true with upper airway cough syndrome or postnasal drip. When you lie supine, the name of the game is eliminating gravity. It worsens. And we already talked about the heart. I don't think this patient has heart failure because there is no PND, there is no lower extremity edema, weight gain, or shortness of breath. But those are three scenarios where lying supine can worsen the cough. And the truth is, the timing from lying supine to how quickly the cough worsens can prioritize even amongst that category. But what else can change with posture? What if you had a mass, a cancer? That gravity is decreasing the blood supply to that cancer. And then when you lie supine and you remove the effect of gravity, you have increased vascularity, enlargement of the mass, and possible stimulation of the cough receptor. But let's hold off for a second about talking about this cough, because the mathematician warned us not to spend too much time on the cough. Let's shift our focus to the unintentional weight loss. That is about 10 pounds, I believe, Api told us, of unintentional weight loss. When you have weight loss, it can either be inflammatory or non-inflammatory. The truth is anything in medicine can be inflammatory or non-inflammatory, but this also applies to weight loss. In terms of inflammation, you can think of infection, malignancy, autoimmune diseases, but there's other reasons for weight loss. What if someone doesn't have access to food? Just picture someone taking a bite of an apple. Where does the apple go? What if they have poor dentition? What if they have dysphagia? What if they have malabsorption, gastroparesis? These are reasons for weight loss. But we now have to shift to something that's even more specific and maybe a pivot point in this case. And that, my friend, our friend, is polyuria. So you may say, wait a minute, Reza, is the polydipsia come first and then the polyuria the appropriate, or is it the polyuria stimulating the polydipsia? The only way to tell is collecting some urine sample, but I bet you it's the polyuria leading to polydipsia, because we have another chief concern is the cough and the weight loss. So whatever this disease is that we're on a hunt to identify, it's probably causing this patient to lose in excess of 4 liters of urine in 24 hours. So Ravijan, I'm putting this on a platter for you. Let's talk about polyuria. Let me pass you the ball and you take it from here. I spoke too much.
Oh, my dear friend, you're putting this on a platter for me, but I am too a sufferer of this condition. I suffer from polyuria. I have to drink way too much water, way too much, and definitely pee more than 4 liters a day. That's what you come to VMR for. Yes, to learn of my urinary habits. I'll tell you, polyuria is easy. Polyuria is either you're drinking too much or you have diabetes. That's it. You're drinking too much or you have diabetes. I didn't tell you what kind of diabetes. It could be diabetes mellitus or diabetes insipidus. So the question, as you said, is, well, how can we make progress? You need a glucose and you need your urine, as you said, but I would say simplify polyuria. You're either drinking too much or you have diabetes. Diabetes mellitus or diabetes insipidus. Diabetes insipidus is further broken down into central diabetes insipidus or nephrogenic diabetes insipidus. But diabetes insipidus is a little bit more complicated because central diabetes insipidus is much more common than nephrogenic. And nephrogenic is usually isolated and not systemic. So if you're trying to prioritize your evaluation for diabetes mellitus, easy, get a glucose. Diabetes insipidus, you have to worry about a systemic disease involving the hypothalamus, and systemic diseases causing nephrogenic diabetes insipidus are rare, but the priority would be to think about hypercalcemia and even less commonly amyloidosis. So remember, if you're peeing a lot, either you're drinking too much or you have some kind of diabetes, mellitus or insipidus. And as Reza said, the urine will help us make a lot of progress. Well, I tell you, last time we had a polyuria polydipsia. I think we're both like, oh my God, it's DI, and it turned out to be the glucose was through the roof. So I can't wait to learn what the glucose is. And if it's new diabetes, that's interesting too. New diabetes mellitus is interesting too. But that's what I would do with the polydipsia polyuria. All right, I'll be back to you.
Yeah, that's a very perfect discussion I have ever heard in my life. So let's move on.
Don't make a bald man blush. You're making me turn red.
So in terms of the physical examinations, vitals, temp 37 Celsius, blood pressure 136/72, heart rate 90, RR 16, O2 sat 94% on room air, BMI 31.4. General appearance, not in any acute distress. HENT, multiple dental caries, no thyroid gland enlargement, and no palpable lymphadenopathy. Cardiovascular, normal S1, S2, no murmurs, and no JVD. Lungs, pretty remarkable. So there's localized wheezing at the right upper lobe with crackles. Other than that, abdomen, unremarkable. Extremities, no swelling and no clapping fingers. Skin, no superficial vein dilatation on the chest wall. Neurological exam, pretty unremarkable. No ptosis and pupil 3 mm, react to light both eyes. Grossly non-focal, basically. And then would you like me to give the basic labs or?
Yeah, I can reflect really briefly on the
Okay,
exam
sure.
and then pass the mic for Reza to reflect on the labs. And I'll tell you that the exam is not too surprising here. In that, what we're dealing with is a very deep syndrome. It's a syndrome of cough worsening with lying down, polydipsia, polyuria, and it's not too surprising that there aren't many prominent clues on exam. But what does stand out is focal wheezing. And focal wheezing usually represents a transient obstruction of a focal airway due to mucus plugging. That's what it usually represents. But fundamentally, what it means is in a specific location, there is some form of obstruction. Most wheezing is diffuse, and most diffuse wheezing is a diffuse obstruction of the bronchioles from either COPD or asthma. But focal wheezing equals focal obstruction, usually implying the focal blockage by mucus plugging. But here we know that the right upper lobe airways are blocked. And the question is, what is blocking them? Is it intraluminal mucus or is it extraluminal compression by some sort of mass? And that I think is going to be the key question. The other abnormality is the dental caries. And I would say most dental caries are incidental to a clinical syndrome. But if you're playing, if you're wondering about a nondescript inflammatory syndrome, you wonder about the possibility of subacute bacterial endocarditis, which is not at play here. If you wanted to get super esoteric and you think dental caries, think scurvy, but please don't think that too often. Here, the major concern is the compression of a bronchiole or a bronchus in the right upper lobe. It might be nothing, mucus plug. It might be something very important, like a compressive mass. Prof. Rez, anything to add about the exam before we get the labs?
Zero.
All right, I'll be back to you.
So for the basic labs, CBC, H and H 1647, white blood cells 13,000, wait, yeah, 13, and platelet 377. Otherwise, electrolytes, sodium 127, and potassium 4.7, chlorine 101, bicarb 14, calcium 9.6. So I might upset a lot of people. Magnesium 1.6, and then creatinine 0.8, BUN 21, and glucose 500. And then other than that, liver function test, total protein 8, albumin 3, T-bili and direct bili within normal limit, as well as AST, ALT, and ALP. So it's pretty unremarkable. Other than that, we did the UA, which revealed no red blood cell, no white blood cell, but glucose 4+, but ketone was negative. We did the blood gas as well, which showed pH 7.37, PO2 83, PCO2 27, and lactate was 0.9. Oh yeah, and we also did the chest X-ray as well, which I can show you the picture of the X-ray. I will share my screen. Oh, actually, I can't share my screen.
Prof. Rez, you might have to make Api co-host that he can share. Do you see how much power Prof. Rez holds over us? Only he can do this.
Can you see my screen? So this is the chest X-ray. Can you see it? Okay. Okay. So there is a mass here at the right upper lobe. Other than that, no consolidation sign, no sign of pool or effusion.
Hey, Api, can I ask you a question? First of all, thank you for, I just am so impressed by how you put this case together. Like the aliquots are perfectly divided and actually showing us an image that is extremely impactful for us and the audience. Api, can you tell me the diff on that white blood cell count? What was the eosinophil? You're muted, Api.
That is what I expected, but I don't have that data. I don't have eosinophil, but I can tell you the percent of neutrophil and lymphocyte, but no eosinophil. I believe that is pretty unremarkable because it's not labeled at red. I think so. That's why I didn't like remember that.
No, thank you so much. And you know, I'm gonna leave the hyperglycemia for Robbie to comment on because I think Robbie, you know, loves talking about hyperglycemia, but he also called it in that first aliquot, and that was the important. So now we look at all this data, and we ask the question: can we explain the patient's presentation and their findings? The polyuria is caused by hyperglycemia. When you have all of those glucose being spilled in urine, water is going to follow. So you're going to become polyuric. And then to catch up, you're going to have a stimulus for thirst because now you're hypovolemic. So your hypothalamus is going to be stimulating you to drink fluid. So we explain the polyuria, we explain the polydipsia. Remember, in patients who are hyperglycemic and don't get insulin, they lose weight. They lose weight. It's a hypermetabolic state. So now we've explained the weight loss as well. What about the cough? Well, the chest x-ray showed the mass, and maybe the mass, like I said, with lying supine, increase in blood flow, probably stimulated the cough receptors, making it worse in that supine posture. So now we've also explained the cough. So now what does our brain have to do? What is our problem representation? 67-year-old woman presenting with a right upper lobe lung mass and hyperglycemia. That's it. So let me talk on all the other data. Leave the hyperglycemia for Robbie to comment on. What I like to first comment is on the CBC. You know, you have to be cautious before saying that this patient had a secondary reason for polycythemia because this hemoglobin is abnormally high for a female. I imagine it's on the higher end. The white blood cell count, normal is less than 10.5, is high. The platelet count also is on the higher end. So this patient has a new term I'm trying to coin, but I don't know if people will agree with this, pancythemia. So not polycythemia, pancythemia, probably from hemoconcentration. So it would be interesting to know what happens when you give this patient fluid and see what their response is. And by the way, you have to be cautious by saying that this patient has normal kidney function because we don't know what their muscle mass is. And point A may be abnormal. And this patient has a reason to have hypovolemia-induced renal injury. The sodium, you gotta be cautious before labeling this hyponatremia. So all you have to do is go look at Jack Penner's approach to hyponatremia. And one of the buckets is to categorize it as hyperosmolar, isoosmolar, or hypoosmolar. And if you measured a serum osmolality here, there will be a component of hyperosmolar hyponatremia. So you can correct it for the patient's glucose And there are formulas you can use for every 100 or 200, you add, I don't know, 1.8 or something between 1 and 2 to the sodium. So the glucose, by the way, is actually an osmotic molecule, because if you don't have insulin around, it's going to pull water from the cell. So it's unlike BUN, which is osmotically inactive, glucose is osmotically active. Okay, so we explained the Chem7, we talked about the CBC. Then you notice there's a protein gap as well, where you take the total protein, which is 8, you subtract it from the albumin, which is about 3, gives you a gap of 5. When you have a protein gap, it's almost like you want to know, is this monoclonal or polyclonal? Monoclonal meaning a single cell, a single plasma cell that has replicated and is secreting one type of immunoglobulin, like myeloma. These are your plasma cell dyscrasias. If it's polyclonal, then you just have to activate the I made mnemonic, infection, malignancy, autoimmune, meaning you have a bunch of plasma cells secreting various immunoglobulins. And I think that I should stop talking, because I think in order to talk about hyperglycemia, you have to link it back to the lung mass. And I'm going to ask the mathematician to add those problems.
I love that. That's such an epic transition. Add those problems. Sugar, sugar, sugar. Why are you so high? You can turn that into rhyme, yo. Sugar, 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 why are you so high? Before you ask that question, you have to wonder, is there a complication of the sugar, sugar, sugar being so high? Is there a diabetic ketoacidosis or hyperosmolar hyperglycemic state? And the answer here is no, primarily because the ketones are negative and the patient doesn't have encephalopathy. So really you're left is, why does this patient have hyperglycemia, which probably, given the severity of the hyperglycemia, translates into why does this patient have new onset diabetes mellitus? How do we know it's new onset? We don't. We don't know it's new onset. We're assuming that it's new onset because the patient seems to have been plugged in with care to be diagnosed with a concomitant disease like hypertension. But if the patient has diabetes, the base, as an adult, the base rate will tell you this is type 2 diabetes. But let's disregard the typical terminology that we have for type 1 versus type 2 to go in a little bit deeper, because as Reza alluded to, the hyperglycemia here is unusual enough that it should serve as something you deconstruct deeply rather than apply superficial labels. So what is type 2 diabetes fundamentally? Type 2 diabetes refers to an acquired form of insulin resistance that blocks the action of insulin, resulting in hyperglycemia. The majority of patients, but not all patients with type 2 diabetes, have a strong genetic predisposition to that acquired phenotype, and a large proportion of them, and I don't know the exact numbers, are either overweight or obese. Okay, so that's the most common cause, is insulin resistance that is genetically mediated and in large part driven or contributed by obesity. What are the real ways you can get diabetes? You can get it because you have a deficiency in insulin or a resistance in insulin. Why would you be deficient? Well, you have autoimmune destruction of your pancreas, like type 1 diabetes, or you have another form of dysfunction of your pancreas that is genetically inherited, and that's MODY, maturity onset diabetes of the young. But you can remove your pancreas in the absence of autoimmune disease like type 1, and in the absence of genetic predisposition in the form of pancreatic cancer that you have to resect the cancer, in the form of IgG syndrome, IgG4 disease, or hemochromatosis, things that take over the pancreas. Now, why do we even mention those? The presence of weight loss in the context of hyperglycemia suggests either insulin deficiency or very advanced insulin resistance. And it's notable to see that there are no cutaneous markings of advanced insulin resistance. There's no acanthosis nigricans everywhere. So I'm running the rare causes of acquired insulin deficiency because the patient has weight loss and no overt signs of marked insulin resistance in the form of acanthosis nigricans. And again, those rarer causes are very, very late onset type 1 diabetes, which is very unusual, but also the possibility that there's a diffuse pancreatic disease like hemochromatosis or IgG4 disease, and some others. There's, by the way, a phenomenon called ketosis-prone diabetes, where patients get transient stunning of their pancreas that then improves. So that's something to think about. But more commonly, you acquire insulin resistance, not through the typical genetic phenotype that we just talked about, not through typical type 2 diabetes, but rather through a list of medications and a list of endocrinopathies. And those medications are things like steroids, whether deliberate or accidental exposure to steroids, things like cyclosporin and tacrolimus. There's a long list of them. And then there are 4 endocrinopathies to think about: Cushing's disease, acromegaly, pheochromocytoma, and the rarest of all, a glucagonoma. Which one of those could be linked back to a lung mass? The only thing that I can think of is Cushing's being linked back to a potentially paraneoplastic lung process. But the case for Cushing's is not robust because there's no ecchymoses, there's no central adiposity, there's no marked leukocytosis, and in most patients with ectopic Cushing's, this would be, there's no hypokalemia, and most important, there's no alkalosis. In fact, the bicarb is low. So let me show you visually for a moment what I was talking about with diabetes as causes, and then we'll move on to explore what caused. But most diabetes in adults, 90% of it is obesity plus family history, where you get type 2 diabetes. But secondary causes can be pancreatic loss, all of the causes here, or certain meds or certain endocrinopathies. So I think it's important in this instance not to assume this is bland old type 2 diabetes, and where this journey will take us, we'll see. But I'll pass the mic to Api to give us more data.
Oh, yeah, actually I skipped something. So she endorsed, actually like she endorsed later that she took the herbal remedy to suppress the cough. So we think that it might be the steroid. So that is one thing that I would like to add. So actually I have a question that like we discussed when we routed this patient. So for the bicarb is 14, but if you calculate the gap using the uncorrected sodium, so at 127, it will be normal gap. But if we use the corrected sodium, then it will be anion gap. So we are not sure which sodium should we use, but we think that, so the UA that we got was like after the fluid. So it's hard to say about the ketone because it could be already resolved.
Api, I'm so glad you asked that question, because we had a friend from Colombia ask the same question, and it's very confusing which sodium to use. And we actually made a video on this. It's 5 minutes long. I'm going to include that in the message panel, where we go through the explanation why you use the sodium that we recommend. But it's all through logic. Okay, so I'll include that in the chat box.
Yeah, so let's move on. So because of the mass that we saw from the chest X-ray, so we did the CT scan. I think I can show you the screen as well. Can you see my slide? I mean like my image. Here there's like 8 by 8 by 7 centimeter of the thick wall cavitary lesion at the right upper lobe that compress the right main bronchus. And then there is like the wall thickness of the mass was around 2 centimeter. There's air fluid level that I got from the report, but no pleural effusion or no lymphadenopathy. So we consulted chest. They did the bronchoscopy to biopsy the lesion. And that's the end of the 4th aliquot.
Prof. Rez, I rambled. Please teach us.
You got it. And if someone can go on our CP Followers account, Robbie, I don't know if you can find that video that we made from our good friend. Thank you so much. We have so many videos on YouTube now, it's hard for me to search. But Api, thanks for giving us that additional information regarding the herbal supplement that this patient was taking, because now we have to update our problem representation And it really comes down to what's causing this cavitary right upper lobe lung lesion. First and foremost, when you have a cavitary right upper lobe lung lesion, ask the question, is the patient at risk of tuberculosis or not? Because you want to keep everyone safe, from exposure to Mycobacterium tuberculosis, which would require airborne precautions in such a case. And a large portion of the world is exposed to TB. But so how do we approach these cavitary lung lesions? You can break it down into 3 buckets: infection, malignancy, and autoimmune. As far as infections, you can then use tempo, which is Queen and diagnostic reasoning, to help prioritize. Is it an acute infection or subacute? We already know that this has been going on for 3 months. So this is not your typical Staph aureus or Klebsiella or Lemierre. If this disease was infectious, it would be more in line with the subacute process. For subacute infections, you can break this down into bacteria, fungal, and parasites. The bacteria, something like a lung abscess, mycobacteria, we talked about TB, or filamentous organisms like nocardia or actinomyces. For fungi, you can think about endemic mycoses like histoblastococcus or even cryptococcus. Now let's go away from infection and let's focus a little bit on malignancy. For malignancy, primary lung cancer in the form of squamous cell carcinoma is the most common of the lung cancers to cause a cavitary lung lesion. In fact, if you go look at our schema, hopefully someone can put that in the chat, you'll see that the cavitary lung lesion used in the example is very similar to the one that Api is presenting. You can have metastatic disease to the lung from the GI tract that can also cavitate, and then liquid cancers like lymphoma. The final category to consider is autoimmune, and here we can list GPA. So where do we fall? Let's use some of the information from this patient to see if we can make any more progress on where we are, okay? We know that acute infection is less likely, just based on the tempo of presentation. We also know that this patient is hyperglycemic, likely from steroids, making them immunosuppressed in some way, shape, or form, based on what Api told us, increasing their predisposition to atypical infection. So we must consider this category, a subacute atypical infection. And Api, can you remind me, where is this patient from and what their travel history is?
So she's originally from Southeast Asia.
Southeast Asia, okay. There's a great mimicker of tuberculosis, which I'm going to pass the ball to Robbie, because every time I try to pronounce this, actually I'll try to pronounce it and then Robbie could correct me. The easy way to say it is melioidosis. The hard way to say it is Burkholderia pseudomonas or something like that. Just say it fast so that people don't judge you. Pseudomonas burkholderia, blah, blah, blah. And then you keep going. The autoimmune category is less likely, although as we age, we're at increased risk of autoimmune diseases too. In fact, in the 50s to 60s, just again, ask Jack Pedner, he'll tell you that's when most autoimmune diseases tend to strike, like GPA, which is exceedingly rare. So Robbie, this is where I am right now. Because of the steroid, the hyperglycemia, the dental caries, an atypical infection, the Southeast Asia location makes me think of TB or its cousin, melioidosis. However, I can't exclude nocardia because we've been fooled on that one too many times, Robbie. I can't exclude cancer. As we age, we have increased risk for cancer. So could this be a squamous cell lung cancer? And I'm looking at her social history to see no tobacco exposure, which is helpful to know, but it doesn't eliminate that possibility. Anything else, Robbie, we can use to make more progress between these 2 buckets?
0.
He says 0, now he's gonna, okay, he really meant it. Api, let me give you the mic and maybe you can actually comment on our thinking and let us know what you were thinking at this juncture.
Yeah, so yeah, we were like thinking the same thing as you just discussed, but like we talked to the radiology, they said that for the thick wall kind of lesion, it's more suggestive of malignancy than infection. That is one thing that I learned from the radiology. Having said that, I can move on to the last aliquot, which is the answer. Actually, we are thinking about like TB as well, because given the history of immigration from the Southeast Asia. And actually, I'm originally from Thailand, so I met a lot of cases of the melioidosis. Yeah. So the biopsy came back, and I can show you the biopsy as well. So it's very surprising for this organism. Actually, it's not.
Let's have Robbie interpret the biopsy.
Yeah, sure.
Okay. No, I'm just joking. Please.
Here. No, I mean
Oy,
like,
oy, 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 oy.
yeah.
I see acute angle branching, which Kushal should tell you what it is because I'm in no place. But I think this is it's surprising, but maybe make sense in the context of the steroid exposure that she had. Kushal, teach us. What's your final answer?
Yeah, it looks like aseptate, acutely branching, and ribbon-like. So I would say rhizopus mucormycosis.
Boom.
But yeah. So, yeah. But it came back actually like for pathology, they read that as an aspergillus, like asper. So the bronchoscopy revealed bronchial tissue with marked acute and chronic inflammation and presence of the necrotic material with fungal hyphae, which is most consistent with asper. So we did send a serum asper, I mean like the aspergillus IgG, and it was positive. So the final diagnosis for this case is the chronic cavitary pulmonary aspergillosis. So patient got voriconazole 200 milligram Q12 hour with drug level monitoring, and then we will repeat the chest X-ray in 2 months and plan to treat this patient for 6 months, but depends on how she responds.
Woo! Hoppy, you kept us on the edge of our seats the whole time. You kept your cards close to your chest and boom, threw out a cavitary lung lesions. And then another surprise twist in the final answer. But I love how you were like, oh, the radiologist thought this was malignancy based on size and kept your cards even close to your chest again, like a true master presenter. I think every presenter, by the way, should have a mic like you have. It looks so much more official when you're like talking into a mic like you did, which is another lovely dimension. So thank you so much for doing this. I've learned a lot from this reflection and from this journey with you all. I'll pass the mic to Reza to see if he has anything to say before we learn from our dear friend Travis.
What I love, well, first of all, Oppie, thank you. I'm going to mention one thing to you really quick, but I love how Kushal says so humbling. Wow, if they had presented me that slide, I would have been like, well, it looks like a past specimen. That would have been it. Robbie, you took it one step further than I could, and then Kushal took it to the next degree. So that was really amazing, Kushal. Thank you for your contribution. Oppie, can you maybe just, first of all, thank you again. This was extraordinary. I appreciate you. Can you just let the audience know what was your idea of the sequence of events? Like what happened first and what happened, et cetera. And then after you're done, we can pass the mic to Travis.
Sure. So yeah, so I think the key diagnostic clue in this case for us when we first saw the patient was the positional related cough. And then because it happened, like we asked the patient, she said that whenever she lies down, just like for a couple of seconds, she started to have a lot of like intractable cough. So we think it's less likely to be from the fluid because it takes time for the fluid to accumulate. So we think it's the local effect from mass that compress the airways or something like that. So we are thinking about mass at that time. And then we look at the chest X-ray, it confirmed that. And then given that patient had like a newly diagnosed DM type 2, probably from the steroid that we mentioned, we think that the patient is at risk of infection, including the TB, which can cause the chronic cough and weight loss. So we actually, like I skipped that part as well. We tested for the TB first, but because of the dry cough, we cannot, the patient could not produce sputum at all, but we treated her as like, like TB rule out. And then because of that mass, we did the chest the CT chest. We talked to the radiology. They think it might be a mass, but actually it turned back to be like an infection from the fungal infection. And so the learning part for me is the how to approach the positional related cough, and then how to diagnose the cavitary chronic cavitary pulmonary aspergillosis. Not only like you have to have the imaging that suggests of the large cavity, but you also has to have symptoms like fever, weight loss, shortness of breath, hemoptysis, fatigue, cough, and also the third part is the positive for the aspergillus IgG. And also like because there is a high likelihood that patient will have concurrent infection with TB, non-tuberculous mycobacteria, histococci, paracocci. So all of that stuff has to be ruled out as well.
Thank you, my dear friend. Travis, take it over, my friend.
Yeah, thank you very much. Just a quick reflection. I know your book is out there. I had the pleasure of reading it when I was on vacation in Jamaica, and it was phenomenal. If anybody needs a break and they need to kind of figure out what is meaningful in medicine again, I think it's important. And Reza, it takes a real man to admit to a lot of those things that you discuss. So I'll leave it everyone on their edge of their seat. I definitely recommend purchasing it. So we started today's case with chronic cough. And what we found is when we choose to form a schema around this complaint, it's important to not get led astray. When you hear chronic cough, pause, study the accompanying symptoms around the landscape, and then go from there. I pulled up a schema and put it in the chat, something that I think Robbie has put on CP Solver's site before. So we next move to another symptom, the orthopnea or orthopnemia, I think is how you pronounced it. And that's when you get kind of more fluid on the left side of the heart, more fluid in the kidneys, leading to more urination at night. You know, when lying supine, that can lead to a low hemoglobin. So what are some things that get worse when lying flat? Upper airway cough syndrome, which used to be called postnasal drip in my day, GERD, and CHF. So taking all those together, you know, what can we rule in, what can we rule out based on some of the other features he has in his review of systems? So we looked at, hey, he doesn't have any PND or kind of any other signs of this being cardiac, like no JVD, things like that, no peripheral edema. So you can take the timing of the symptoms as well, and him developing the shortness of breath when he's lying supine, you know, whether or not it's something pulmonary or PND like we discussed. Then we moved on to the weight loss. You know, is this inflammatory or non-inflammatory? So infection, autoimmune, malignancy, or the other non-inflammatory causes. As we got some more information, we found that he had polyuria. And could this have been the pivot point that we were looking for? Every time we're getting a case and we're getting the history, we're looking for those things. And whether or not that pivot point is going to come in the HPI, in the social history, in the labs, in the physical exam, I think we're always trying to figure out what's signal and what's noise and what's our pivot point. So, you know, is the polyuria, could that be leading to the polydipsia? Are you drinking too much water? I think like Robbie alluded to, you know, or is this from diabetes mellitus or diabetes insipidus? When you get to the diabetes insipidus, it's either central or nephrogenic. Central is more common, nephrogenic is more rare and more localized. Think hypercalcemia and amyloidosis. Next, we moved on to the exam. And I think a big pivot point here, because we found some focal wheezing. So that represents obstruction in a focal area, usually implying mucus plugging. But what's blocking it? Is it mucus or is it something extra luminal, like a mass? Then we also noted that he had dental caries. Dental caries can be assigned for certain things. some of the more esoteric causes like scurvy or something else like endocarditis. And going from there, those with hyperglycemia, they'll lose weight because they lose water with the polyuria. So now we have a mass that's explaining the cough. Now let's kind of change up our problem representation and keep it simple. And the labs, we saw we had some pancythemia, which Reza coined as having high platelets, high hemoglobin, high white blood cell count. So that's all hemoconcentration. We had a protein gap, gamma gap. Now, when we have that, is it monoclonal or is it polyclonal? I think we all love discussing plasma cell dyscrasias. And in the polyclonal, we should activate our I may mnemonic, which we like to do in CP solvers. And I guess, fast forwarding a little bit, to finding this cavitary lung lesion where radiology had a high suspicion that this was malignancy. But also think about other things. Acute infections, subacute infections, the acute being staph and Klebsiella, the subacute being nocardia, Kuchal's favorite melioidosis, and fungal causes, like we found that this was aspergillosis. And then also malignancy, squamous cell carcinoma, METs, lymphoma, and autoimmune disease causes like GPA. So it was a great case, multiple teaching points here. Thank you very much, everybody for joining, and we'll see you tomorrow.
Crushing it, Travis. Crushing it. Have a good day, y'all.